With that, we're going to go on to the next small session of cases. So Dr. Hura and I are going to present on IOL role-playing, act the part, make the match. I think maybe I'll sit there as your doctor. Huh?
I don't know about you, Neda. I already did 2 rounds of food, so I'm feeling good. Yeah, sit right there, right there. Perfect.
All right. Is this on? Okay, good. I'm a very friendly doctor here. I sit next to my patients.
This is how all of our consults start.
Exactly. Actually, you know what? I need the clicker. Let me get the clicker here. All right. So hi, should we call you Dr. Hura as my patient?
You can call me Arjan.
All right, Arjan. Hi, Arjan. Welcome to our clinic.
It's such a pleasure to finally meet you, Dr. Shamie. I've heard wonderful things about you.
Well, thank you.
Your social media is so amazing.
Am I likable?
I feel very comfortable right here. Right now.
Am I likable on my social media? I hope so. All right, so let's actually let's get into why you're here. Tell me what has brought you into our clinic and what are your goals with your eye care?
Well, when I was very young, I had a really bad prescription. I had a very hard time seeing, and I had old school LASIK, and they made a lot of cuts on my cornea, and I was seeing really good after that. And just the past few years, I'm going through multiple pairs of glasses. My vision's changing throughout the day. I can't see anything clearly anymore, and I'm just using a contact on one eye, and it's not really helping.
Okay. So old school LASIK, do you mean that you had RK? Does that sound familiar to you?
Something like that, yeah.
Now tell me, so you must have been very nearsighted before this.
I couldn't see anything.
Couldn't see anything. And the RKs, how do they work for you?
They were really good for a few years, and then I realized in the morning my vision was different. It would get better throughout the day, and my optometrist was able to fit me with a couple pairs of glasses, but now I have 3 or 4, and I'm losing them all the time. Sometimes the glasses break. It's just hard to keep up with everything.
Got it. And you mentioned that you wear contact lens in one eye. Is that a gas-permeable hard contact lens or a soft contact lens?
You're talking about, is it that small hard? It's a soft, I think.
Soft contact lens. And the purpose of you wearing a contact lens in one eye is that to give you better distance vision?
It's to help me read.
Help you
Everything
read.
I do is on the computer. I'm looking at my phone all day for work. I can't see without it.
Okay. All right, so this is the director's commentary. So a couple of things. First of all, patients who had RK are now at an age where they're developing cataracts, and it's not uncommon for us in our clinic to now see them back for cataract. And as you all know, an RK patient has very abnormal corneas. There's a lot more at stake than their cataracts, and there's a lot in the history that can guide us in making a decision as to how to guide their patient towards the right lens option, towards the right visual outcome, and also how we can potentially meet their expectations. A couple of things in the history that really helped me is that any patient who's had corneal refractive surgery, a very important question to ask them is that, did you have good vision, or did you appreciate your vision up until the point that the cataract started developing? So if the patient was struggling with their vision and for, soon after refractive surgery or a few years later and has been reliant on gas-permeable contact lenses or just simply is not happy with their vision, that's a patient that you have to really consider a very highly irregular cornea. And what are your thoughts as to what type of lens implant you would implant for them? A post-RK patient, it's really important to ask them what time in the day is most important to them, because as you know, an RK cornea shifts throughout the day. And if you check the biometry and do your IOL calculations early in the morning when they don't have to leave the house until later and they're really reliant on the best vision later in the day, then you may miss the opportunity to hit their refractive target. And so I often ask the patient, at what time point do you feel that you want to really have the most optimized vision, and ask them to come in for their biometry measurements at that time. So more specifically for this patient, for Arjan, his uncorrected visual acuity is 20/60 in the right eye, 20/70 in the left. As you can see, he's developed some flattening of his cornea over time, which is not unusual in post-RK eyes. And he's now about a +3 in the right eye and corrects only to 20/30, and then has significant astigmatism. Actually, the left eye has astigmatism, and he wears a presbyopic pair of glasses and bifocals. But then he also has contact lenses. So He wears a +6 contact lens in the right eye. He was prescribed this to give him a monovision. So interestingly enough, he's done well with a soft contact lens. So this tells me that, one, his expectations must not be very high because, again, with that irregular cornea, with a soft contact lens, it's not hiding the corneal irregularities. And if he's happy enough, this is a patient that I'm willing to really kind of encourage towards a creative option to give him the best visual outcome possible with the least amount of dependence on glasses and contacts. Now, if Arjan told me that his vision wasn't so good and he's been struggling, possibly even would tell me that he's been using the gas-permeable contact lenses for the best vision possible, then I'm not going to be looking towards getting him contact lens independence, because if he's been reliant on gas-permeable contact lenses, chances are he's going to have to return back to a scleral lens or gas-permeable contact lens. And in that patient, I would then recommend a monofocal lens implant. So Arjan has a 16-cut RK in the right eye and an 8-cut RK in the left. And there's definitely some scarring adjacent to his pupillary axis in the right eye. So I'm thinking the right eye is a lot more irregular than the left, and I may have to come up with kind of a creative way of giving him that monovision outcome that he's enjoyed and he can tolerate, but possibly maybe address his irregular cornea. So I'm going to jump right into considerations in abnormal cornea. Again, highlighting if the best vision is achieved only with a gas-permeable or sclerals, you want to think that the cornea is the main contributor to vision and that we consider a standard lens. Would you agree that that would be the approach?
Agreed.
This is when you're in your doctor shoes.
Oh, okay. Whatever you say, Dr. Shamie. No, I agree.
If the central topo is irregular, avoid a toric and avoid presbyopia correcting lenses. So we really look closely at that topography. And what we are looking at is that central 3 millimeters of the topography. As you can see, this is a patient with ectasia or with keratoconus. I would not, even if they have high astigmatism, given how irregular that cornea is, I would not be recommending a toric lens. Now, here's another patient with a pellucid-looking cornea. Now, but the central 3 millimeters of that corneal topography is mostly bow tie. And typically a patient like this, their vision can be corrected with a soft contact lens or glasses. And in this case, I would consider a toric lens. I still would avoid a multifocal lens. And then, again, with the bow tie patients, you can do toric, but multifocal, I have done some multifocals, but it would really have to be rock solid, stable, and perfectly bow tie. Now, put on your doctor's hat. Would you agree with kind of even pellucid keratoconus as long as that central 3 millimeters
is
bow
regular
tie,
and normal? Yeah, I think it just comes down to stability, like you said. If we're seeing signs on serial topography, if we're seeing a changing refraction and it's been getting worse, the complaints are getting worse, and it's not necessarily in line with the cataract, then I'm very hesitant to recommend sometimes even a toric. But if it's regular, central 3 millimeters, typically they're going to see good after surgery. But we always have to also consider, even though we're not really inducing a lot of astigmatism with surgery, depending on how that bow tie is, especially peripherally if it's skewed, it's possible it could change a little bit after surgery as well.
And sometimes if you're not sure about the contribution of the cornea to the vision, whether it's the cornea or the cataract, what's really helpful is a gas-permeable contact lens over correction. So some of the doctors in the audience who have shared patients with me, sometimes I send the patient back and say, can you please do an RGP over refraction to give us that kind of real added information to help delineate the contributions to vision. So option for this patient, we could potentially go the kind of the easy route, standard target plano, and use the Ascaris nomogram for RK, and then have the patient continue doing soft contact lenses, but still will have to be dependent on contacts. Another option is doing a standard with monovision, or LAL both eyes target monovision. That's definitely a fantastic option and one that has worked well for many of our patients. But then how about mixing and matching? And I think that's something I really pride ourselves in doing, and that is customizing treatment plans to patients and mixing and matching. And in this patient, I went ahead and put in a small aperture IOL in the non-dominant eye, the right eye. Thankfully, his non-dominant eye has the more irregular cornea, and then the dominant eye got the light adjustable lens. And in fact, the final outcome was fantastic. As you can see here, the 1 month post-op in the non-dominant eye is J1+, and the dominant eye, uncorrected visual acuity of 20/20. And this patient, with a creative option, was able to really gain the kind of visual outcome that he was seeking. So congratulations, you have great vision.
I'm so happy.
All right, on to your case.
We're going to get into this a little bit later in our last talk about sort of the mechanism of action of small aperture optics, why it works so well in these irregular corneas. But I'll just say it is tends to be very forgiving for these RKIs, pellucid marginal degeneration, keratoconus, and it's a fantastic option that we've been happy to add to our armamentarium. So we'll switch roles here a little bit, I suppose. Now, Neda, I'm going to be the doctor. So, oh my gosh, what lovely glasses you have.
Thank you very much. But I'm here actually to get rid of these glasses because I am done with it. It's very frustrating for me to wear glasses.
First, welcome to the Maloney-Shamie Vision Institute.
Yes, hello.
And we're happy to have you here. Tell me, what part of town are you coming in from?
I'm coming from Los Angeles and excited to be here. I've heard so much about you, and again, I want to re-emphasize because this is why I'm here, because I've heard that you are the master in getting me out of my glasses and contacts.
Okay, well, tell me a little bit about that. Do you mostly wear glasses throughout the day? Are you on contact lenses?
Yeah, you know, I used to wear contact lenses, but I have some dry eyes, and so it's become more frustrating. I'm not able to tolerate contacts very much, but I'm reliant on glasses pretty much for everything I do, from the moment I wake up until I go to sleep.
Okay, and so you're wearing glasses full-time now. How old were you when you were first in those contact lenses?
I was about 15 or 16.
Okay.
Yeah.
Okay. And right now, how is the vision in the glasses throughout the day? Are you realizing that the prescription's just not as good as it used to be?
The prescription keeps changing, and I have a lot of glare and halos at night, and a lot of difficulty with reading, and can't see the street signs anymore.
And tell me, when you're having trouble reading, how do you fix that? Are you taking your glasses off? Are you putting on contacts to read?
No, I pretty much read through my glasses.
Okay.
But do you want me to read something?
Yeah, sure,
okay.
sure.
All right. So
take a look at this.
So yeah, I usually read through my glasses, and
okay.
This is very typical, by the way. So you hand it over,
yep.
read.
Okay, all right. I think I understand.
Or better is like this.
Yep.
Right. Okay.
Yep. So already we'll put a pause on this conversation. So it's interesting. As surgeons, a lot of times we're seeing these patients for the first time, right? And the optometrists in the community, these are your patients. You've been seeing these patients sometimes 15, 20, 25 years. You know these patients inside out. And so your recommendations about not just their eyes, but their personality as well, can be so informative to the conversation. But one of the things we really do, even asking innocuous questions like, where are you from? What do you like to do for work? What are your hobbies or passions? You know, Neda jumped right in talking about her glasses. To me, that's already telling me a little bit something about herself. So if I redirect the conversation and she's going back to that, I'm already thinking about, okay.
Are you saying I'm high-strung?
I didn't say anything. But, you know, we tend to have these patients in all parts of the country, but especially here in Southern California and sort of in Westwood and Beverly Hills where we practice. So this is already, before I've even taken a look at her eyes, before I've even looked at the numbers, this is already, you know, making me think a little bit about what direction am I going to potentially take this conversation in.
I'll add that I just recently had blepharoplasty and a facelift, and so I want to look I want my eyes to be as young as how I look.
Okay. So clearly this is a patient who, and so Neda, if I had a magic wand and I could kind of wave it and give you the vision you seek, what would that look like?
Well, I want to go back to when I was 20 years old, and even better than 20, because back then I had to wear contact lenses. So I want to be able to see as great as I look. I'm 72, but I look much younger because I just had my nice facelift. Yeah, I want to be able to drive without having to wear glasses. I want to be able to read without, and then be at a restaurant, look at the menu without having to have glasses on. And I want to have perfect vision, like 20/15 vision.
So it sounds like if we could get you out of the glasses, get you seeing great at all distances, distance, intermediate, up close, that would be ideal for you.
Yes, absolutely.
Okay.
But it has to be perfect vision.
Perfect vision. Let me ask you, tell me, you mentioned sometimes your eyes are a little dry. Was that only in contacts, or is it when you're wearing glasses as well?
No, I think sometimes also in glasses. I've been told that I should use artificial tears, but it messes up my makeup, and I don't go out without makeup.
Okay. So I'll put a pause again on the conversation. So a patient who wants perfection, they want it all, they want to be out of glasses and contacts. pretty much the only thing that's going to get that patient that level of vision is a multifocal IOL or some form of monovision, provided that they've done well with it in the past. So some patients naturally are born with monovision, they love it, or they've been with monovision and glasses or contacts for 5-10 years, they'll do great with that. Then maybe we could explore either true monovision or some version of a monofocal plus IOL or an extended range IOL with monovision to give them a broad range of vision. But it's pretty much one of those two things. And so we're going to forward here to the exam. So Neda's vision, 20/40 in the right eye, 20/50 in the left. Again, this is why she can read so well without glasses, -2, -2.5 OS, and gives a history of taking glasses off to read, occasionally has used dry eye medications, and on exam, the right eye ocular surface, not that bad, maybe a little areas of dryness there, but the left eye seems a little bit more dry. And when I look at her OCT macula, the right eye looks great, good foveal contour, no fluid, flat. The left eye, there's an ERM there. And so this is ultimately now going to potentially change the direction this conversation goes in.
Can I add a
Yes.
doctor's hat note? The -2s to -3s and such are some of the most challenging ones to really meet their expectations for many of the reasons that Arjan was mentioning. And because they don't understand that they can read without glasses because they're myopic. So they're expecting we're going to be able to correct their vision for distance, but they want to, and then we say, well, these are the options, but I don't need any of those options because I can read without glasses right now. And so it takes a lot of conversation around that.
Yeah, the multifocal lenses, extended range lenses, these work great in the right patient with the right eye, with the right personality, with the right brain. There's a lot of criteria that need to be met. And we know if you look, last year we presented, Dr. Shamie presented a great talk on defocus curves of all the lenses, and I think that's still available online. But just inherent to diffractive optics, inherent to the way light is stretched with an extended range lens, there is a slight reduction in contrast sensitivity. Now, for the vast majority of people, it's not something significant. Photographers, designers, cinematographers, they tend to be much more discerning with their visual system and what they need to do on a day-to-day basis. So it can be a little bit of a bad option for those patients. For a patient who doesn't want to deal with glare and halos, if it's not coming from, let's say, cortical cataract, if that's really what one of their complaints is, I shy a little bit away from the multifocal. When I look at this patient's eye, the retina looks great in the right eye, ocular surface not bad. We could maybe talk about a multifocal or extended range here. But if we look at the left eye, I know that that reduction in contrast sensitivity from the ocular surface, compounded with that ERM, compounded with the defocus curves of an advanced lens, the patient is not going to be happy. This is the patient who's maybe reading 20/20 on the chart, but they're just complaining they can't see anything. The quality of vision is not good. The challenge we sometimes run into when patients have cataracts is if they've never tolerated monovision or they've never even trialed monovision, it's hard to get a very accurate feel for whether they would do well with monovision or not. This is a particular patient, you know, let's say
Just call me particular?
Oh, your doctor hat's still on. Let's say the ocular surface didn't really look that bad in the left eye. The ERM is either more mild or not even present. This would maybe be a great patient to discuss the light adjustable lens, and we'll discuss sort of this in our other talk as well, because that would give someone then a chance to do a pseudophakic monovision trial after surgery to really see if they like it. Obviously, expectations would need to be set beforehand, saying, hey, ultimately, if you don't like monovision, then we're going to have to focus on either distance, intermediate, or near. But for this patient, I think a multifocal lens in the right eye, especially if it's the non-dominant eye, would give a broad range of vision, and then we maximize the quality of distance vision with just a monofocal lens in the left eye. And I think for this patient, that would probably be a good compromise. And there'll still be some situations, dim mood lighting, small font on a menu at a restaurant, where maybe a light pair of readers would be needed, but ultimately it would be better than putting a multifocal in both eyes and then the patient's miserable and they want an IOL exchange. And doctor, why didn't you tell me this? You told me you were going to give me perfect vision. These are the nuances of the conversations, yeah.
If I can also add, I think it's really important, the nuances of that conversation, as you mentioned, and making sure that the patient understands that you're listening to their needs and presenting all the different potentials to them. And we often, if we have a patient who's sitting there and is highly motivated to have freedom from glasses and contacts, even if there's mild reasons why we may wonder if they would be a good candidate for multifocal lens, we don't hesitate recommending that if we feel that they're highly motivated, they really want to be vested in this process, because we can exchange lenses, although that's not desired. So We do hold back that recommendation unless the patient really pushes forward, and then we work with the patient, make sure their expectations are realistic.
Yeah, final point on this, both of these cases were situations where we mixed and matched. Both eyes had different IOLs. Very important beforehand that we counsel patients, don't compare one eye to the other. The optics of each lens are different. The vision in each eye is going to be different. One of our good friends, I stole this from him, he tells patients, you know, we have two ears. You don't walk around life covering one ear at a time and trying to listen. You shouldn't be doing this all the time either. And I think also when we're trialing monovision, that is something that can be a deterrent to successful neuroadaptation, is if patients are constantly doing this. And it tends to be those particular patients who are doing that the most.